Good morning, but also good afternoon and good evening to some of us. It is our pleasure to welcome you to this ITM webinar focusing on COVID-19 in Belgium, and more particularly on the question, what does the COVID-19 crisis teach us? Need for a comprehensive response balancing multiple perspectives. This webinar is part of the ITM community webinar series on COVID-19. The main aim of this webinar is to share experiences, expertise, and good practices within the ITM community of staff, students, alumni, and the wider global health community. Our today's moderator is Professor Dr. Bart Kriel. Bart Kriel is a medical doctor by training and professor at the Public Health Department of the ITM Antwerp and currently director of the MPH course, Orientation, Health Systems and Disease Control. He has vast experience in the study of health systems and policies in various sub-Saharan African countries, but also India and Belgium. His principal domains of interest and expertise are twofold: the management of local district health systems in a primary healthcare perspective on the one hand, and the design and management of social health protection policies in a universal health coverage perspective on the other. Bart, please.
Thank you very much, Charlotte, for this nice introduction. Welcome to all of you in North, South, East, and West to this webinar with Professor Lieven Annemans. I will perhaps first start with let's say, a more formal, a short formal introduction of Professor Annemans and his CV. Professor Annemans studied at the Vrije Universiteit Brussels, the Free University of Brussels, where he obtained different master degrees in physical education, but later also economics, and he obtained a PhD in applied economics. Professor Annemans is currently professor of health economics at both the Ghent and the Brussels University. In the period 2000-2003, he was advisor to the Belgian Federal Minister of Social Affairs, Frank van den Broeke. And there seems to be a bit of a pattern. Many people who have been involved in advising Minister Frank van den Broeke have somehow shared similar critical views on the Belgian health system. Professor Annemans, during 8 years, chaired the Flemish Health Council. And in 2014, he published a book in Dutch, but the title in English is "The Price of Your Health, Is Our Healthcare Endangered?" Wherein he presents a critical analysis of the Belgian healthcare system. And strikingly, his plea is not per se to increase the funding, but rather to reorganize the system and try to obtain more efficiencies. Since 2015, Professor Annemans leads the National Happiness Research, and he's currently member of various working groups advising Belgian federal and regional authorities on the exit strategy out of the COVID-19 induced lockdown. Now, a bit more off track, I would say, in terms of the personality of Lieven Annemans. He's, I think I can say, probably the most famous health economist in Flanders. And my grown-up daughters actually said, well, Dad, look, this is a professor with long hair and a ponytail, so this is something that strikes. But more seriously, Professor Annemans, and more importantly, is his ability to explain complex things in an understandable way, which is a great skill. In this epidemic, COVID-19, Lieven Annemans first came into the picture through a short piece somewhere in April, if I recall well, in the Flemish newspaper De Tijd, where he had a corona conversation with an unbeliever on the relevance to sustain a lockdown. And for the first time, slowly, prudently, the issue of cost effectiveness of the lockdown was put on the agenda. And the question was raised, how far do we go in the avoid deaths at any cost? Already then did Lieven Annemans point in his reply to the non-believer to the importance of mental health. And this will definitely come back in the presentation. Also later in May, in a long article in the Morgen, Professor Annemans said, oh, at least that was one of the quotes taken over by the journalist, we should have protected our elderly people better. Our mental well-being should from now on be the priority. Feelings of depression having increased, having doubled in Corona times. In that same interview in the Morgen, Lieven Annemans said healthcare workers would deserve a better remuneration, but there is need for more than only that. And he has always put the need for ethics central in the thinking. If we reflect on cost effectiveness, it's not only about mathematics; it's also about ethics. Good. In his presentation, Lieven Annemans is going to have a plea for a more balanced approach to approach COVID, with room for different perspectives. And in the short text on his presentation, which was shared with you, he ends with a sphere of vigilance and citizenship should be promoted than a sphere of anxiety. All very interesting and very promising. Yesterday, when preparing this webinar with Professor Annemans and my colleagues, he clearly explicitated the objective and the expected output of this webinar, and that is to make people think. Professor Annemans, Lieven, please, the floor is yours.
Okay, thank you, Bart, for this very kind introduction. Good morning, good afternoon, good evening, everyone. Indeed, as Bart already explained, my goal of this lecture is to make us all reflect and think and try maybe to do it better next time if there's going to be a next time. And even today, we are now beginning of June. What has happened, of course. But as from tomorrow, we can try to, wherever we have the possibility, to improve the well-being of our citizens by taking the right measures. So that is my main goal: is reflection, think, and try to not have a tunnel vision, because that is sometimes happening, unfortunately, in this crisis period. So, what's the content? First of all, the pros and the cons of a lockdown in case of a pandemic. Then I will take one step back. I'm a health economist, so I want to explain to you the key health economic principles. Then the third point is, can we already say now whether the lockdown was or is cost effective? And I will share with you a back of the envelope calculation. So not high science, but at least an attempt to try to estimate the cost effectiveness of the lockdown. Then I will go further into the downsides of a lockdown with some facts, but also some estimates. And then I will end up with a conclusion, and of course, we will have plenty of time then to discuss. Of course, you know that in the meantime, there are already thousands of publications around COVID-19, and I cannot claim that my lecture is based on a systematic review. So any lecture today and in this period has some bias, because the one who is preparing the lecture will select his literature in function of what he wants to say. So I can't claim a systematic approach, but I hope, as I said, to make you help reflect on this crisis and its consequences. The first thing that you see here is from the European mortality monitoring, the Euromomo. It's nice to follow up that website, because it clearly shows the excess mortality in a given region or country. This is what you see here, the excess mortality in Europe, and expressed in number of deaths per week. So on the y-axis, you see the number of deaths per week, and on the x-axis, you see the different weeks. It goes here up to week 17 of 2020. You see the previous years, and as you know, every year in Europe, we see excess mortality due to the seasonal flu. Despite the flu vaccination, 2017 was a very bad winter with, at its peak, 70,000 deaths per week, despite vaccination. And now we see in this COVID pandemic, we see a peak of 90,000 deaths per week. So clearly this is a severe condition. For those who are still hesitating, this is a really severe condition leading to a lot of mortality. And the goal of many countries was the following. They called it flatten the curve, because without doing anything, the fear was that the healthcare capacity would be overruled. So that means it would be not enough to take care of all these severe cases of COVID-19. And in the meantime, we know that many cases go without symptoms, but there is a small part with severe symptoms, and those patients need to be hospitalized. And so there was a fear that the healthcare capacity could not make it. And so the main goal of the protective measures was to flatten the curve and to stay within the healthcare system capacity. But in most countries, it went further than that. The system capacity was indeed protected, but the lockdown continued. It was going on. And the question then indeed raised, I asked that question indeed, Bart, at, I remember it very well, it was the 31st of March, where I indeed raised the question, how far and how long should we go with this lockdown? Flatten the curve, yes, fine, but what next? And shouldn't we already start thinking of exit strategies? The moment that we start with the lockdown, we should already have a plan also to exit from the tunnel. And so the key question is, yes, but what would have been the excess mortality without a lockdown? I just have shown you the excess mortality shown by the European mortality monitoring system. But the question is, what would have been the result without a lockdown? And there has been a nice paper from the Cochrane group published in April this year, of course. And what they did, they did a systematic review of the existing models, because many models are now published, or results of models are published. Some are not published. Some modelers are still sitting on their data and on their model because they don't want to share it with anybody else. But luckily, many modelers, epidemiologists want to share their estimates with the community. And what these authors here did, they did a systematic review of the published models. And they came to the following very interesting conclusion. They said the modeling studies consistently report the benefit of the simulated quarantine measures. For example, quarantine of people exposed to confirmed or suspected cases averted 44% to 81% incident cases and 31% to 63% of deaths compared to no measures. As you can see from the range, different models predict different results, either with or without measures. But it shows anyway that the lockdown had an effect, and many deaths were avoided. So that's good. But a lockdown also, and especially a long and intensive lockdown, also have negative consequences. And I create here 3 building blocks. The first one is related to financial losses, unemployment, and poverty. Some people will lose money, but will not get into poverty, but they will lose money, and they don't like that, of course. Some will get into unemployment. Some will get, if they were not yet into poverty, they will get into poverty. Second building block is mental health problems: stress, anxiety, burnouts, depression. And I will show you later on some data. And the third one is other non-COVID-19 related morbidity and mortality: cardiovascular disease and cancer. Why? Because in many countries, also the healthcare system was locked down. Only really necessary care could still be delivered, but there was confusion about what is necessary care. And there was also fear among patients who needed necessary care and didn't want to come to the healthcare centers. So also there, leading to morbidity and mortality. Now, this has been already described by others, of course. Here a nice picture shared on LinkedIn by Dr. Christophe de Smet from Belgium, who says there are 4 waves. There are different pictures and with different numbers of waves, but I like this one because it's quite explanatory. So the first wave is the one that we were talking about: immediate mortality and morbidity of COVID-19. And we know that the lockdown has flattened that curve. The tail of the first wave is what is called the post-ICU recovery, or the post-hospital recovery, because not every patient ended up in ICU. Many ended up in a COVID department, but also they, once discharged from the hospital, many of them still have sequelae of their acute COVID-19 episode. The second wave is the impact of resource restriction on urgent non-COVID conditions, as I just mentioned, the cardiovascular, the cancer progression, and others. The third wave is then the impact of this interrupted care on chronic conditions. So patients with diabetes who are not well followed up, what I just said, also cancer. It could be, and that is the second wave, that new cancer was diagnosed too late, but it could also be that patients already with existing cancer, that their progression of disease is also observed too late. And that will have then long-term consequences also for those patients. And then the fourth wave is psychic trauma, mental illnesses, economic injury, burnout. That is the biggest wave, according to Dr. De Smet, that is now already starting and that is going to continue for many months. That was by way of introduction. Now, I'm a health economist and I want to share with you what we do. We try to do many things. We do studies on burden of illness. What is the cost of cancer in Europe, for instance? We make recommendations on healthcare system reform, how to optimize the healthcare system and which financial incentives are needed, etc. But a core element of what we do consists of health economic evaluations, cost effectiveness studies. And I will briefly take you to the basics of that cost effectiveness. I need to do that because then you will understand what I want to share afterwards regarding the cost effectiveness and the balance that we have to find in dealing with the pandemic. So the view of the health economists is the following. We need healthcare interventions, we need treatments, programs that clearly offer a benefit to patients, reducing morbidity and mortality, of course, that fill unmet medical needs. So we are not waiting for new interventions for comfort problems, we are waiting for new interventions for real medical problems. They also need to be cost effective, and I will explain what we mean by that. And they also need to be affordable. And those are the four key elements that we are looking for. And I will explain especially that concept of cost effectiveness. We express effectiveness in QALYs, quality adjusted life years. And it's a very simple concept. It's more difficult to measure, but to explain, it's quite simple. Imagine a patient with a life expectancy of 20 years. And that patient has a quality of life which can be expressed between 0 or 1. 1 is perfect health, 0 is death. So this patient is still alive, so clearly has not 0. This patient has, for instance, 0.5. In our jargon, we call it, by the way, the utility level. It's a typical economic term. There are methods to measure that, of course. For instance, the Euroqol 5D or the SF36. This patient has 0.5. Imagine that the patient stays on 0.5 for the next 20 years. That means 20 years at the quality of life of only 0.5. That means 10 quality adjusted life years, simply 20 times 0.5. If the patient would live 20 years in perfect health, then he would have 20 QALYs, but now the patient lives 20 years only at half the health, so that's only 20 times 0.5 equals 10 QALYs. That means that if we have treatments that can improve quality of life, or here, for instance, the patient goes to 0.6 thanks to treatment, we have now 12 QALYs, so we gain 2 QALYs. Or if we can prolong the life of a person, in this case, the patient now lives 5 years longer at a quality of only 0.5, so that means we gain 2.5 QALYs. And the best of all is treatments and programs that can improve the quality of life and also prolong the life. The last example, I will not go into the details, but obviously if you have a benefit on both quality of life and life expectancy, you can gain a lot of QALYs. Here we gain in total 5 QALYs in this example. So the goal in healthcare is in fact to try to gain as much as possible QALYs for patients, but of course not at any cost, because we don't have all the money of the world to spend on healthcare. Health and healthcare are key aspects of our lives, but we cannot spend all our money in a given country on health and on healthcare, so we have to make choices. And that's where cost effectiveness comes in. So we work with 2 dimensions, the cost dimension and the health effects, and the health effects are then expressed in QALYs. And we compare to the situation of doing nothing or current care. In many cases, there is already an approach. We call it then the current care. And then we see that health programs cost money, of course. And that's the blue arrow. We are increasing the cost because we are introducing a health program. That can be a vaccination program, that can be a screening program, that can be a new treatment for HIV, etc. So we are inducing costs because of that new program. But that new program can also lead to cost offsets in the system. Thanks to that new program, there are less hospitalizations, for instance, and we are going to save money. Sometimes these cost offsets are even bigger than the original investment, and then of course we have a beautiful story. Most of the time that is not the case. So most of the time, yes, healthcare programs cost money. Yes, there might be some cost offsets, but you can see that red arrow here, that means that in total, everything taken together, the healthcare program will cost money. That's the red arrow. And then we have to look at QALYs. How many QALYs are we going to gain with this healthcare program? And only then we can come to a conclusion. And the conclusion can be three things. Or we end up in the green zone here, in the right below part, meaning our healthcare program will lead to net savings, so our cost offsets will be larger than our investment, and we also will gain QALYs. Health economists call this a dominant result. We gain twice. We save money for the healthcare system and we gain QALYs for the patients. But second possibility, the healthcare program is very expensive and the benefits in terms of QALYs are rather modest. Then we have to admit this is not cost effective. We spend a lot of money, and with the money that we invest, we only gain a little bit of health. That's wasted money. We could have invested that money much better if we would have used it for other healthcare programs. So this is an example of a non-cost effective healthcare program, the one in red here. The remaining one, the third one here, is costing more money to the system. But for each euro or dollar or any other currency that we consider that we invest, proportionally we gain a lot of QALYs. So the investment is reasonable, the gain in QALYs is large, so the ratio between cost and effects is acceptable, and therefore this is a cost-effective program. In more and more countries, we work with thresholds. A very well-known threshold is in the UK, and the threshold size is £30,000 per QALY. So the idea in the UK is, if you calculate the costs and the effects of your program, and the ratio remains below £30,000 for a QALY, then it is cost effective and we should invest in that healthcare program. However, if you are above 30,000, we're really sorry, this is not cost effective. We cannot invest in that program. This is ethical. Bart talked about ethical aspects in health economics. It would be not ethical to waste money for a program that is not cost effective, because that money is not anymore available for other people who are more in need and where the money could be better spent. Simple example, imagine a new treatment that costs £60,000. I pretend I'm still in the UK. You can't hear it from my accent. It's not really UK accent. £60,000 investment, 3 QALYs gained. That comes down to £20,000 to gain 1 QALY. We call it the incremental cost effectiveness ratio. If it costs £60,000 to gain 3 QALYs, that comes down to £20,000 to gain 1 QALY. And that's a good result because we remain below the threshold of 30,000. I give a second example. A treatment that costs £100,000, it only leads to 0.5 QALYs. That comes down to £200,000 to gain 1 QALY. Indeed, if it costs 100,000 to gain 0.5 QALYs, that means £200,000 to gain 1 QALY, and that's way above the threshold. That is not a good investment in healthcare. So that was the promised intermezzo, a very brief course on cost effectiveness. And now the key question, of course, is how do we deal with that? Well, before going back to COVID-19, one final remark. In the Netherlands, and not only the Netherlands, there are more and more countries that say, wait a moment, it's not that simple. The medical need also should play a role, and it's based on, again, ethics. Skitowski said, that there is an acceptable level of health. It's not perfect health, it's an acceptable level of health. And if people are far below that acceptable level of health, they suffer a lot because of cancer, because of a severe rare disease, of multiple sclerosis, etc., then we have to do more for them. And those who have a condition that is close to the acceptable level of health, or those who have a condition where they are even above the acceptable level of health, there is not such a need to invest as a society in helping them because they have more a comfort problem. And so in the Netherlands, they took that seriously and they adapted their threshold. And in the Netherlands, they say that for a mild disease, the maximum willingness to pay of our society to gain QALYs is only 20,000 per QALY. But for a severe condition, we are willing to go up to 80,000. Even when life is threatened, we want to go up to 100,000. So the threshold I was talking about, the famous 30,000 pounds that is applied in the UK, in the Netherlands, they say, yeah, but we have to adapt that threshold. There is no single threshold. For severe conditions, as a society, we want to pay more, and we want to go up to 100,000 euros that we are willing to pay to gain a QALY. So we are increasing the threshold and allowing more and more expensive treatment programs to gain QALYs. And now the million-dollar question, was that lockdown then cost-effective? And in fact, question B, is maintaining a lockdown cost-effective? I did a back-of-the-envelope calculation, and based on the cost that was published by, and I did it for Belgium, because I'm based in Belgium, I have easily access to the Belgian data, and I did it for Belgium. The calculations that I do here are very easily adaptable to other countries. And again, it's back of the envelope. You can criticize it a lot, but it makes us think. So this is coming from the National Bank of Belgium, who clearly shows what the impact will be of this crisis on the gross domestic product. 100 is the index. In the first quarter of 2018, the GDP was growing. And then because of the crisis, a huge drop of more than 15%, and then catch up again. So it's not really a V, it's something, yeah, different than a V, but that's what we see. Of course, when you have this data, you can also calculate the cumulative impact on our GDP. How many billions of euros are lost? And that cumulative impact is shown here. So based on the same report, because of the crisis, and we start now here in the Q1 of 2020, the cumulative loss for Belgium is currently estimated, and it goes on until the end of 21. The total cumulative cost is estimated to be 60 billion of euros. Okay, that's what we are giving up as a society because of this lockdown. Now, the question is, of course, there are many questions. How many people would have died without that lockdown? Well, I'm coming back to that systematic review that was published by the Cochrane group, Nussbaumer, the slide that I showed in the beginning. And I use an upper limit of the range. So we assume that 60% of deaths could have been avoided. So that means that without the lockdown, there would have been 24,000 deaths. I round the number. So that means a difference of about 14,000. So more than 14,000 lives have been saved because of the lockdown. And McAllister and colleagues recently published, that's a Scottish group, that for each life that you save here, you gain around 10 QALYs. And that's, by the way, a misunderstanding. Some people say, yes, but those who die are all 85 and older. That's not necessarily the case. There are also younger people. And by the way, somebody of 85 who dies from COVID-19, it doesn't mean necessarily that this person otherwise would have died already a month later. Some would have had a life expectancy still of 3 to 5 years or even more. Bottom line is that McAllister and colleagues calculated that for every life that you save here with the measures that were taken, that you gain 10 QALYs. So that means 14,250 lives saved, each of them representing 10 QALYs. That means 142,500 QALYs that are saved because of the lockdown, but at a cost of 60 billion. So that comes down to more than 400,000 euros per quali. There are some data missing, of course, in this back of the envelope. For instance, the cost of the hospitalizations, but also the cost of the hospitalizations if there would not have been a lockdown, because then many more people, remember, many more people would have been hospitalized. The hospital capacity could not follow. So all of that needs to be taken into account. But this already provides us with some order of magnitude. And as you can see, it's above the threshold. But again, remember, we were early March in most countries. At that time, not going into a lockdown would have been a quite dangerous decision with many more deaths, as I just show, with the hospital capacity not being able to follow, etc. But my point is that if you do this, then you have to think about the intensity of that lockdown and the impact, as I said, on all the other aspects. And that's why I'm coming back to the famous waves. Remember the 4 waves that I described in the beginning of my lecture? I want to come back to the 4th wave first, because the 4th wave, we also see there as one of the bullet points, the economic injury. And that's what I want to start with in order to look at the further consequences. This was recently published in the New York Times, How Modi failed the pandemic test. The starkest failure of the government's coronavirus strategy has been the devastation it imposed on the country's workers. So clearly, the biggest impact is the economic impact, and there are many publications like that. I'm showing you again a number from Belgium. The Belgian Federal Planning Agency, end of April, published a report where they estimated, already based on the data that were available, what is going to be the impact of COVID-19 and especially the lockdown measures on material deprivation and on the absence of social network. In Belgium, although it's a rich country, we have already 4.6% who live in severe material deprivation, that have no money to buy a decent meal and to buy decent clothes. And because of this crisis, this will increase to 6.6%. So that means a 2% absolute increase. Now, 2% absolute increase, that means 230,000 Belgians additionally ending up in severe material deprivation. This is my back of the envelope calculation number 2. 230,000 people. We know that the healthy life years lost for the most deprived compared to the second most deprived is 4 life years. What I mean by that is the following. We all know, there is a lot of literature about that. There is a lot of socioeconomic gradients in healthy life expectancy. And most authors, they publish the difference between the most deprived and the most affluent, the most wealthy people. And then we see numbers in the literature of 15 years difference, for instance, that the most deprived have 15 years less of healthy life expectancy. Here, I took a more conservative assumption because I assumed that those getting deprived were before already close to deprived. So the difference I make here is the most deprived versus the second category, just above the most deprived. But already there is a difference of 4 years. Of course, that is from birth. And those getting deprived, they get deprived on an average age, some at very young age and some at very old age. So I simply cut it by 2. So on average, those becoming severely deprived are in the middle of their life expectancy. And so I take 2 years lost healthy life years. So our 230,000 people who become deprived, that will lead to 460,000 qualis lost if we're not going to do anything about it. So if we just accept that these become deprived and we are just not doing anything, we risk to lose 460,000 qualis. Remember, the lockdown has led to 140,000 qualis saved. It makes us think. And there are many papers on that. There's a recent one from Wim van Lanker, also a Belgian social scientist. The COVID-19 school closures will lead to child poverty and will increase the gap between the development potentials of children of lower socioeconomic groups compared to those who are in affluent groups. So the gaps are going to be widened because of this crisis. Same paper from South Africa. Children are the victims of the measures taken to halt the spread. They have been denied basic rights of access to healthcare and to education. The schools have been closed, and for many vulnerable pupils, this has meant an experience of isolation, anxiety, and hunger. These restrictions may be considered a form of abuse or neglect. So that is really a strong statement, but it's a true statement. We should not have done that. Then I move to the mental health care problems. Our Belgian National Office of Health, Cienzano, so the Scientific Institute of Public Health, has recently already published that during the lockdown, the prevalence of anxiety has increased from a little bit more than 10% to 20%. So this is prevalence, and compared to the prevalence of 2019, same episode. So that means that what you see here are in fact new cases. It's comparing prevalences of two episodes, but in fact, it results in fact in a conclusion about incidence. It means that during this lockdown, so many more people suffer from anxiety, and the same for depression, from 10% to 16%. And that's, again, that was a number of Belgium. I always try to first show Belgium and then open it to other examples. This is a nice study conducted in southwestern China. As you know, in China, some parts of the country have been affected by lockdowns, other parts of the country have not been affected by lockdowns. This study has compared different regions, and as you can see, so the upper part of the table is anxiety, the lower part of the table is depression, affected group, so affected by lockdown, or unaffected group, unaffected by lockdown. And you can see prevalence of mild depression in the affected group, 7.9% compared to 5.1% in the unaffected group, and especially moderate, this is anxiety, moderate anxiety, 4.5% compared to 1.2%. Severe is not so much affected. Depression, 11.2 versus 7, moderate 9.8 versus 3.5, so almost times 3. And then the severe 1.4 against 1.1. So a clear impact, especially on mild and moderate depressive and anxiety symptoms. And then the third block is the missed medical care. This is again a number from Belgium. So how many people had their visit to a general physician cancelled or delayed? How many got a telemedicine care? And how many had the usual consultations maintained? So GPs, that was okay. Well, okay, they're still about 25% cancelled or delayed. Psychologists, psychotherapists, psychiatrists, 60% cancelled or delayed. Medical technical treatments, 65. Investigations, 70. Specialist consultations, almost 80. Rehabilitation sessions, almost 90. So all of that care was cancelled or delayed. And the patients, that was from another study, the patients reported from their own perspective that 10 to 20% of that delayed or cancelled care was leading to severe healthcare problems for the patients. I'm just showing a study from Italy, from a group of cardiologists. It's a long text. This lockdown has drastically reduced non-COVID-19 access to emergency rooms. They say, admittedly, this might also have resulted in reducing improper access to emergency rooms, because in many countries, indeed, some people go for nothing to the emergency room, for a broken nail, for instance, but that has, of course, also decreased. But it substantiates the risk of underestimating problems not connected to COVID-19, such as increased delay in the diagnosis and treatment of acute myocardial infarction and other cardiovascular emergencies. And indeed, it's only one example. But we see that during this crisis in many countries, people came too late with, in this case, cardiovascular symptoms. And we know from the literature that, and I show you a recent study in the European Heart Journal from Scholz and colleagues, we know from the literature that if you have symptoms of a heart attack, the longer you wait to get treated, the more it increases your mortality. Here it is published in that paper based on 12,600 patients with heart attacks. different kinds of severity of heart attack, the 4 curves, and then the impact of in hospital mortality in function of the time to getting a treatment for your heart attack. So the longer you wait, of course, the higher the mortality of those patients. And that leads then also to lost life years. My group at Ghent University is currently estimating, I was hoping we would be ready by today, but we are currently estimating also what that means in terms of lost QALYs. In the next few days, we will publish, no, not publish, we will report those results next few days or weeks. That will depend on how fast we work. So, what is my conclusion, or what are the elements for discussion? I think that, first of all, and maybe I was not really doing that well during my lecture now and then, because what I want to say now is, first of all, let's not point to people what they did wrong. You did this wrong, you did that wrong. We are now early June. It doesn't help anybody to say, and you there in May, you took the wrong decision. That's not really helping anybody. But what we can do is think of whether there will be future COVID-19 waves. The models are not in alignment there. Some say yes, some say no. Or in case of future pandemics of this kind, it's better not to lock down, but it's better to focus on physical distancing, social bonding, washing, testing, face masks. So the generally accepted protection measures, but not a lockdown. Why? Because if we do it with a light approach, like physical distancing, social bonding, I don't like the word social distancing. I prefer physical distancing and social bonding. Washing, testing, and face masks, that will have a much less impact on the economy. It will have less impact on anxiety and depression, and it will have less impact on other diseases. And in total, we will have more QALYs for a population than in case of a lockdown. Now, also there are already studies simulating this, and I find this one very interesting, Cambridge working paper. And you have to bear with me, it's my last slide. What you see on the left side is the impact on consumption, and that's one of the parameters to show impact on the economy, of course. The impact of consumption of doing nothing. And it's good that these authors did that. They said, imagine we would have done nothing. That would have led to even more. That's, remember what I said in the beginning. And it would also have been a damage to the economy. You see here a decrease of almost 10% and then slowly picking up. But the dotted red line that you see here, if we would take only measures of physical distancing and washing and masks and testing, that would also impact consumption, but much less. That's the red dotted line. The right part is, again, doing nothing. And the blue line that you see there on the right is in fact the same blue line that you see on the left, but the scale is different. So you recognize here also, again, the drop in consumption of 10%. So the blue line here is the same as the blue line there, but the scale is different. Because what is the impact of a lockdown? It's an immediate drop in consumption of more than 35% and then slowly picking up. So clearly, the physical distancing would affect the economy much less than the lockdown, and therefore, and even less than doing nothing also, as you can see on the left side. And that's why this is going to be the right choice, in my view, in case of a next wave or in case of a next pandemic. So this is all I wanted to share with you. And now the floor is open for questions and for discussion. I will also stop sharing my screen, then we can talk. I was about to say face to face, but at least we see, you can see me again. All right, Bart, up to you.
Yes, okay. Okay, the questions are coming in gradually. Let me perhaps take a first one. Lieven, you mentioned missed medical care. Now, what part of it, what proportion of it you think was essential care? thinking back of the book that you wrote a couple of years ago, there's quite some unnecessary utilization, over-medicalization. So what is, let's say, appropriate care that has been missed versus non-appropriate care? Would you have an idea on that? Could you elaborate, please?
Yeah, there are in the literature different estimates on the percentage of inappropriate care in different healthcare systems around the world. Estimates goes from 10% to 30%. And it also depends on the interpretation of inappropriate care. For instance, if guidelines say that a given patient needs to be followed up once a year and that patient is followed up 3 times a year, it's not abuse, it's not fraud, but it's simply overconsumption. It was 2 of those 3 visits, and typically with that visit there will be investigations, etc. 2 of those 3 visits were not necessary and could then be called inappropriate care. And there are many examples of that. But some are more tolerant in the definition of inappropriate care, and others are more strict in the definition. And that's and also the size of it is also different from country to country. That's why the range is quite wide, somewhere between 10 and 30%. We will be able to see that, by the way, because during the crisis, care that was non-essential and not urgent was cancelled. And we will see that only some of that care will be catched up later on, and others will not be catched up later on without any special consequences for the patient, which then will point to care that was in the end not needed. But I wanted to focus here more on the one that was needed, and that's still the majority, because even if inappropriate care is 30%, it means that appropriate care is still 70%, and not having had that care will have consequences.
Okay, thank you. Another interesting question is that, well, you focused on the increase in anxiety and depression during the lockdown, and it shows indeed an increase compared to a normal 2019. Now, should that not be compared to the hypothetical figures of just letting the epidemic happen? People might have been happy to be able to do the normal thing.
Yeah, yeah, indeed. And that's what I was saying. And so what I liked about the Cambridge paper is that they compare the 3 scenarios. They compare doing nothing, and then more modest measures with physical distancing, etc., and then a strict lockdown. So in fact, most of the studies that we are now seeing is the impact of the lockdown compared to the year before in terms of anxiety and depression, or like the study in China, a lockdown region versus a non-lockdown region. But that non-lockdown region was not locked down because there was also almost no epidemic. So the question that indeed we have to ask is, if nothing would have been done, what would then have been the impact on anxiety and depression? Indeed. Yeah.
Okay. There is also an interesting point on the Cochrane, between inverted commas, rapid review. The authors themselves say that the certainty of the evidence is low to very low because it's based on the number of assumptions and we don't have all the knowledge yet. So could these sort of, what about the reliability of these models? Is there not a risk that they may be used for political ends, that may in the medium and long run have enormous economic and health costs for our populations? Yeah. Should we not be more careful about what we propose as evidence or science?
Yeah, indeed. Yeah, most models that have been published are based on the what well-known SEER logic, suspectable, exposed, infectious, and recovered. And depending on the parameters that go in your model, you predict quite different things. And that's why I try to be careful when interpreting models. I try to look into the parameters that I used and then try to indeed carefully draw conclusions. what I liked about the one from the Cochrane is that they did a systematic review of the models, and that despite the fact that models have a large level of uncertainty, that the range already points to some order of magnitude. And remember, when I did my back of the envelope, I took the most optimistic part of the range. So the most optimistic estimates are that 60% of deaths have been avoided by the lockdown. So in that case, there is less risk that I could be blamed of underestimating the impact of a lockdown. So that's why I took that part of the range.
Now, in the cost-benefit analysis, we focus on, or you focused on early loss of life. Now, if healthy life years were lost, this would also have an impact on pension payments, end-of-life healthcare costs. Is this somehow computed in the cost-benefit analysis, or can this be computed therein?
Yeah, excellent question. So when we do cost effectiveness studies, as I explained, we look at the cost dimension and the quality dimension. And in the cost dimension, you have a choice between different perspectives. The mostly applied perspectives are either the healthcare perspective, and that was the one that I explained here. So what is the program going to be costing in terms of healthcare costs, but also what are the cost offsets in terms of healthcare costs? Or you can take a broader perspective, namely the societal perspective. And then it means, what does it cost to society, a given program? And also, what are the benefits to society? So the benefits to society can then be expressed in gained productivity or the avoidance of lost productivity. So if you save the life of a patient of 45 years old, then you are gaining productivity. But I didn't want to go that much into detail, because once you are talking about expressing lives in terms of productivity gains, there are two schools of thinking. One is the human capital school. That means that if you lose the life at the age of 45, that school says that we lose 20 years of life productivity, because normally that person could have worked until retirement. But there is another school, the friction cost method, and they say, no, if somebody dies at the age of 45, that person will be replaced by somebody else. That somebody else will also be replaced by somebody else. And somebody who had not a job before will then find a job because of that cascade of job filling. And in the end, the lost productivity to society is only about 3 to 6 months. So much less. So yes. I didn't want to go that much into detail, and that's why I called my calculation the back of the envelope calculation. Yes. But to be correct, it should be taken into account. Yeah.
In the same line of ideas, Professor Annemans, there was another question on the QALYs 1 through less air pollution. I mean, that's the same sort of discussion to broaden up the, let's say, the computation of the benefits.
Yeah, indeed. And that's also a difficult one, because indeed, temporarily, we see that in many countries, the pollution data look quite better than before. The question is, if the economy is picking up, to which extent will also that be compensated by worse data in that relaunch phase? Again, a big responsibility for policymakers to also in the exit strategy to not have a tunnel vision and to not go to business as usual. And maybe, for instance, I give an example. If you give subsidies to companies, why not giving subsidies to companies that can prove that they are investing in sustainability, for instance, of our planet, and less subsidies to companies that are more polluting, for instance. So that could be a nice measure. But I did not take it into account in my calculations because it's too difficult.
Yes.
At this point.
Okay, still a question on the QALYs, which apparently triggers lots of interest. If a next virus would affect children, which is not really the case now. Children may be infected, but have hardly, if any, symptoms. Now, if they would affect children and they get sick, then QALYs will not perhaps be 10 QALYs lost, but perhaps 80. And so you would get into very different conclusions.
Yeah, indeed, of course. Generally, 2 points there. Generally, when you gain quality of life and life expectancy in children, the number of QALYs gained are much bigger. We see that, for instance, in projects. I'm thinking now of projects in the field of hematological cancers. If you save the life of a child with leukemia, you gain 60 QALYs or something like that. If you save the life of an older person with chronic leukemia, you gain much less QALYs, of course. Second element, if there would be a virus that is primarily affecting children, then of course our story would be completely different, and the way that we have to address it is of course also completely different. Then there is no other way out than to close schools. But even in that case, we should be prepared to give every child the right to still have good education. What I mean by that is that, as you know, and that was also in that paper from Van Lanker, the beauty of schools is that you reach everybody. If all children are supposed to go to school, at school you reach all children. If children cannot go to school, it leads to a delay in their development, of course. And those who are from the more affluent groups, their delay in development is much less because they have several computers for one family, and every child can work on its own computer, etc., etc. So that means that if we want to be prepared also for a pandemic that affects children in the first place, there is a need for investing in material to be able to give children also good education at home when that would be needed.
Professor Annemans, one of well, perhaps the main conclusion of your presentation is that if we would have future COVID-19 waves, better not to lock down. Now imagine that if indeed this is followed as an advice, and we'll come back to that later, how the current YES group would react to your conclusions. But if there would be no lockdown and the healthcare capacity is being reached, what then to do? Would then some kind of lockdown be justified to safeguard somehow that capacity?
I think if you look at different countries in the world, most of the countries did not really have a good pandemic plan. And it means that elements like testing, elements like understanding and recognizing that a virus can also go unsymptomatic or asymptomatic in many patients, recognizing all of that would help to react much faster. So my point is that here, and again I said at the beginning, because of be taken by surprise by the virus, there was, I think, no other alternative than to lock down in order to flatten the curve. But if you have a pandemic plan, then I think, I'm not a virologist, so I have to be careful what I'm saying, but if you're prepared, and I'm thinking of, imagine it's a respiratory virus, of course. If you're prepared for a respiratory virus, it means that there will be sufficient masks. That means that test capacity can be, because the RNA of this virus was known very rapidly. So tests were able to be developed also quite rapidly. And if you know that this is going or can happen, you can make sure that test capacity can go much faster than it happened now in many countries. So the point is that it will be less unpredictable because there will be less planning, and in that case, it could be, for instance, a partial lockdown and partial quarantine for those who are infected, for instance, but not a total lockdown. That's the difference.
Good.
I'm also not saying, again, and I hope I did not give that impression, I'm not saying that, oh, nothing was needed. That was the idea of some, oh, let's just wait and see and how it leads finally to herd immunity. And that is definitely also not the way to go. The way to go is somewhere in between, where we can still save our economy and where still people with other diseases can go to the hospital, but where we still stop the virus to the same extent as what a lockdown was able to do.
Okay. Professor Annemans, there's a question on the interaction between experts and policymakers. And you are, as an academic, you are a voice that is listened to. You are part of a number of commissions looking at the management of this epidemic and trying to make proposals for the future. Now, your conclusion is, well, better not to lock down. Can you say a word on how the group of experts looking at the exit strategies react to that? Also, taking into consideration the news that was in the media yesterday, that it seems that the Belgian authorities are absolutely not prepared to a second wave. So, how would you appreciate this? This interaction, and are your conclusions listened to? Do they have a chance of being taken up in future policies?
First of all, as you know, Belgium is a complex country. There is a federal level and there are the regional levels. At the federal level, I've only experienced in what they call the sub-working groups or the sub-task forces. So there was the overall task force with experts, and they relied then on sub-task forces regarding the healthcare system, regarding mental health. So there I was only part of two sub-task forces. So I was not holding the pen of the final advices to the politicians. At the regional level, the Flanders region, there has been a relaunch committee installed, and I'm part of that relaunch committee, and we are supposed to give advice to the government about how to restore our society. So there is an economic relaunch and there is a societal relaunch committee, and the societal relaunch committee has the task to give advice about how to restore our society during and after this crisis. And there we are not yet ready. So there I cannot yet say how politicians will respond to our advices. I can testify that the better the advisors are prepared, and the more they are in consensus and supported by evidence, the more politicians listen to it. And that's a more general statement. I used to be many years the chairman of the Flemish Health Council. We had to give advice on all kinds of health-related issues to the Flemish Minister of Health. And the Flemish Minister of Health did not have to follow our advice. It was not a binding advice. But when our advice was very well supported and very well documented, the minister followed our advice. In some cases, the minister did not follow our advice. And I have to admit, sometimes the minister was right. The minister came with better arguments than what we had, and therefore decided not to follow our advice. And that's a good way of working. And both the advice and the decision of the minister were, of course, made public, so that everybody can also of course, see and challenge what was said and written. That's a good approach. And I cannot say much more yet about what we are doing on the Flemish level now for the relaunch committee, but at least what I can say is that it is well prepared with a clear mandate for the experts, with good support, with an additional agency that helps us in getting the evidence and bringing it together. And of course, we can work indeed in that situation, whereas in the situation of crisis, you can imagine that developing advices is a very chaotic process because it has to go very fast. And I think that has led also to misalignment between experts and politicians.
Yes. You recommend in your conclusion, well, to focus on physical distancing. Now, how can this be imposed without forbidding many things that are part of our lives, such as mass events, larger family gatherings, cultural events, which may also have major impacts on the economy and the mental well-being? How to manage this?
Yeah, indeed. again, doing nothing would not be the right choice. So I think you have to do something. And that's why, yeah, a complete lockdown is not the right choice either, if a new pandemic wave would exist. And that's why the nuance is somewhere in the middle. And of course, it will then depend on the granularity of the measures. Who needs to respect physical distancing? Do we apply 1 meter or 1.5 meters or 2 meters? Because also there is already a misalignment. What does it mean in terms of if you take 1 meter, you can put many more children in a classroom, for instance, if you decide that children need to respect physical distancing, which is also another question. Should that be the case, yes or no, in case of a virus that is affecting adults and elderly in the first place? Should we focus lockdown only for the elderly in the sense that there indeed we have to protect them, and so it's a partial lockdown. So all kind of elements play there. It's again finding there a balance between, if you take a given measure, what will be the impact on the economy, what will be the impact on the well-being of people, and what will be the impact on the virus. And you always have to balance those three elements. I have seen the exit scenarios of the state of Massachusetts in the US, and they looked at measures always looking at 2 dimensions already. So the impact on the virus and the impact on the economy. I would suggest to have a 3rd dimension, namely impact on the well-being of the population, the quality of life, the mental health, etc. And then it can lead to better decisions.
Okay. Professor Annemans, there are half a dozen questions on the case of Sweden, which is, has been the subject of controversy or great admiration. They have used a different approach. Could you elaborate? Sweden has not gone for a very dramatic lockdown, quite loose measures, initially relatively limited deaths. The data seem to indicate otherwise. Now, could you, on the basis of the analysis you've done here for Belgium, how would you look at the case of Sweden?
Yeah. Of course, who am I to say something about Sweden, what I should have done and what I should do next time? I'll try. It's again the same story of that continuum: doing nothing on the one hand and severe lockdown on the other hand. What Sweden was doing was on that continuum quite closer already to that part of doing nothing. They did a lot of things, of course. It's not doing nothing, but they did. But what I was just explaining in my answer to the previous question was a little bit moving more towards lockdown, because I was talking about a partial lockdown and immediate testing and masks, use of masks, for instance, if physical distancing cannot be respected. So the combination of measures that I was talking about is going more to the other side of the continuum than what has been done in Sweden. And of course, there are also, well, you could call it bad luck, or you could call it also an example of underestimation, which happened everywhere. I must admit, in the beginning of this pandemic, I had also not good data about how many people had no symptoms and were still infectious. So also in Sweden, what happened there is also that many elderly got infected because they got infected by people who had no symptoms and yet were infectious. So you cannot blame anybody for that. If you're taken by surprise by a virus, and we have seen it in many countries that also nurses in nursing homes have infected elderly people, despite the fact that that nurse was non-symptomatic. And that's also part of what happened in Sweden. I'm not going to say more about it because comparing countries is difficult in the sense that, because I could compare, I could look at the excess mortality in Sweden. It's still much less than the excess mortality in Belgium, although the lockdown in Belgium was more strict. So you have to look at the cumulative numbers. But I should not do that comparison because countries have different population density, countries have different levels of pollution, and maybe pollution has played a role also in the reproduction number of the virus. There are so many uncertainties that it becomes difficult to compare countries, and it's always apples with oranges.
Yes.
But I think it's fair to say we have to find our position on that continuum somewhere between doing nothing and a complete lockdown.
Professor Annemans, many of the people attending this webinar are working in low and middle income countries. We are the Institute of Tropical Medicine, so many of our alumni and collaborators are working in the South. So there's a question, more than one question, well, the conclusions you put forward now are, of course, conclusions for the Belgian context, but could you nevertheless comment? I know it's not your domain of expertise per se, the health systems in low and middle income countries, but nevertheless, could you comment on the general attitude chosen by low and middle income countries who did not go directly in a total lockdown, and also given the context that the pandemic peak has perhaps not yet been reached as in other countries. So not an easy question, but what would you advise cautiously for low and middle income countries?
Yeah, of course, Bart, you told me beforehand that part of the audience would be from low and middle income countries. That's also why I did a little bit extra research to also bring in some evidence from there. I'm afraid you see the same issues as I was discussing, namely impact on unemployment, impact on poverty, impact on mental conditions, impact on other medical conditions. You see them at least to the same extent also in low and middle income countries. And I'm especially concerned about the increase in poverty and the widening gap between the affluent and those who are living in difficult conditions. And maybe this crisis should be a wake-up call also for leaders in those countries and also leaders in the West, because the West has a big responsibility there as well, to try to close that gap and to reduce socioeconomic inequalities. In the end, we know that reducing socioeconomic inequalities, there are beautiful examples of some countries that managed to do that in the past. It leads to better welfare and well-being for everyone. And that's sometimes still underestimated by those who have a good life. They underestimate the impact of reducing socioeconomic inequalities on the entire society.
Okay, perhaps coming back to our context, or it may also be valid for other contexts, you have asymptomatic confirmed cases. How to go about to avoid that these people become the pariahs of the society? I mean, you know, you have, if Belgians want to travel during their holidays, they may, depending on the country they want to travel to, they may have to present a sort of certificate that they are not infected. How to handle this sort of behavior, which obviously has substantial psychosocial and mental impact?
Yeah. There is a phenomenon that we see in healthcare. It's called blame the victim. We use that more, for instance, for smokers or for people with obesity. They are sometimes also stigmatized and blamed, and some people even say they should not get reimbursement for a treatment. I tend to disagree with that approach and that attitude, because they are victims, but they should not be blamed. A smoker should not be blamed. The smoker is a victim of our society, a society that allows tobacco companies to produce tobacco products. Patients with obesity is a victim of our society, because we have an obesogene of society, and the unhealthy food is much cheaper than the healthy food. I think we could draw that parallel here. If you are infected by this virus, it's not your fault. You should not be blamed. Many people get infected by others despite the fact that they are not taking risk behavior. Okay, some do take risk behavior, that's true, but as a general rule, I think we should apply here the not blame the victim approach. And simply, yeah, okay, bad luck, you're infected, you cannot travel now, wait 2 weeks. Hopefully by then the serology tests will be of good quality and then we'll show that you're immune. And that's another story, that immunity. That's something that, yes. That will also in the next weeks reveal some surprises, I think.
Okay.
But that's another story. So yes. My answer would be, let's not go into a blame the victim attitude.
Yes. Professor Annemans, I'm looking at time. I would propose to slowly get towards the end. May I ask you a question on the vaccine, the possible vaccine that may be available in months, perhaps more than months from now? Well, a big issue is going to be vaccinate what population first, how to establish these priorities. What about low and middle income countries, etc. Could you elaborate a little bit on, let's say, some of the health economics perspective on that, but also the ethical implications to that sort of difficult decisions that we will have to face in the times to come?
Yeah. I would say, first of all, again, we have to always look for nuance. People have the tendency to go too fast into one or other direction. Also, with regard to the vaccine story, I hear some people saying, until we have no vaccine, we will be in big misery. And only when there is a vaccine, that will be the big salvation. I don't think that, first of all. Second, if it would be needed sooner or later to have a vaccine, I don't think it would be a good idea to vaccinate the entire population. So we know now from recent estimates published in the Lancet that the mortality rate of the virus is now estimated at 0.66%, so about 6 per 1,000, and especially in the elderly. So I think it would then be a better strategy to, if we need a vaccine. So my first answer is, I'm not yet sure that would be the salvation, but if it would be the case, then it would be more logical to look into high-risk population and of course elderly are part of that, but not to have a full population strategy. That's my view with the current knowledge that I have about the virus and its behavior.
Okay, well,
let's not forget maybe another point, Bart. Currently, there are 800 clinical studies ongoing, on most of them on repurposed drugs, antivirals, but also anti-inflammatory drugs that counter the cytokine storm, anticoagulant treatments, etc. So there are many trials ongoing, about 800 or even more. It would be surprised if nothing would come out of that. So it means also that the treatment plan, in case of a second wave, or for those who are still in their first wave, the treatment plan will also be much better than the treatment plan that occurred in the first couple of weeks of the pandemic. And again, that will help to reduce the panic and to deal with this virus in a more serene way, and with good guidance on how to approach it once you have symptoms, what to do with patients with not yet severe symptoms, what if the severity increases. I'm pretty sure that as time goes by, that this treatment guidelines will be better and better with better and better options.
Professor Annemans, I want to raise a last question which pertains to the elderly, and more specifically the elderly in our Belgian and European rest homes. There was a very comprehensive article in the Standard over the weekend giving insight in why the situation in the nursing home became a total mess, unlike in what happened in most hospitals. Now the article explains, tries to put forward a number of explanations. There are many reasons for that. But was it indeed, you think, as a bit advocated also in that paper, an accident waiting to happen because of perhaps too much a search for efficiency in running the rest homes, with implications on availability of staff, training of staff, etc.? Could you elaborate, let's say, on also the broader societal lessons and implications of that dramatic situation in our rest homes, specifically here in Belgium?
Yeah, we know from studies that on average, resting homes are about 15 to 20% underfinanced, and automatically that has a consequence on available staff and available medical care capacity, because it's not only caring for these elderly, but also medical care, because many of them only get to a resting home because of medical problems, of course. So that is true. But apart from that, and we have to do something about it for sure. Apart from that, I'm afraid it was also, again, a combination of underestimation and bad luck. Many nurses, without knowing, have infected elderly, because the nurse itself was not asked. The guidance said if you are not symptomatic and the elderly person is not symptomatic, you're not required to wear masks. And it was even weeks after the start of the crisis that this guidance was still there. And that should have been replaced by a guidance that every professional staff, nurse, caring people, cleaning people, needed to wear masks, because we know, and it was apparently not clear for many, but we know from the literature that a mask is not protecting yourself. I mean, I'm talking about the simple masks, the surgical masks, the tissue mask, the paper mask. They are not protecting yourself; they are protecting the other one. So if I go to the supermarket, I wear a mask, not to protect myself, but to show to other people, look, I want to protect you. I have no symptoms, but still I might be infected, and therefore I might be infectious. So I wear a mask in order to reduce the chance that I transmit the virus. That should have happened from the start, also in the resting homes. And that will happen hopefully with the second wave, if there was going to be a second wave.
Would you also plead to have more staff actually in the rest homes? Now the rest homes are largely being run in terms of care by nurse aides that have perhaps not the necessary training in maintaining hygiene, etc. So there have been cut savings over the years, the decades, and this is somehow a crisis waiting to happen. So there's need for much more investment in human resources. Would you?
Yeah, exactly. I was too short in my first part of my answer. The 15 to 20% underfinancing has as an automatic consequence that you have understaffing, and not understaffing in quantitative terms and in qualitative terms. So not enough staff, but also not enough medically trained staff.
Okay, thank you very much. Dear friends, North, South, East, West, all of you, thank you very much for having attended this webinar. I think it has been exciting. I think we, Professor Annemans, we fully reached the objective, make us think. There are many still questions that we may have to consider, that are pondering. Now, this webinar is going to be recorded. It will be shared on a larger scale, and we are willing, Professor Annemans, to centralize possible questions that people may still have and share them with you later, so that everybody can have the opportunity to have his questions responded to. So thank you very much, Lieven, for your time, for these very nice presentations, and thank you all of you. All the best, and please remain healthy. Bye-bye.
Thank you.